Hello, welcome to our 8 in 8 series. My name is Boris Sepesi. I'm a director of thoracic surgery and thoracic medical oncology at UCHealth Sarah Cannon Cancer Network in Denver, Colorado. And I will talk about the neoadjuvant biomarker trials in lung cancer. It's not necessarily exhaustive, but these are some of the most important trials, biomarker trials in neoadjuvant treatments. So I would like to just review the current landscape of the perioperative neoadjuvant and adjuvant treatment in lung cancer. As we all know, there have been multiple trials over the last 3 to 5 years that have matured. These were phase 3 trials and have been many of these have been approved by FDA. So in the neoadjuvant setting, we currently have a Checkmate 816 trial. This is a trial that used 3 cycles of chemotherapy plus nivolumab, followed by surgical resections for patients with tumors greater than 4 centimeters in size, and also positive mediastinal lymph nodes. So based on AJCC 8 staging, this would be stages 2 through 3B. The Keynote 671 trial was actually a perioperative trial that gave 4 cycles of neoadjuvant chemoimmunotherapy, followed by surgery, followed by adjuvant therapy. Patients were randomized to placebo versus immunotherapy. Checkmate 77T was also a very similar trial that gave 4 cycles of neoadjuvant chemoimmunotherapy, followed by surgery, followed by adjuvant therapy for 1 year, and so was a GN. All of these trials have used different types of immunotherapy regimen combined with surgery. The Empower 030 trial have not necessarily read out yet. In the adjuvant trial, we have Empower 010. This was a trial that was done following surgical resection up front, followed by chemotherapy, followed by adjuvant therapy with atezolizumab. The other trial was PEARLS or Keynote 091. This was with pembrolizumab, also a very similar trial where patients underwent upfront surgical resections first and then received chemotherapy and adjuvant pembrolizumab. All of these trials have been now published. In the biomarker-driven lung cancer, we actually have level 1 evidence for EGFR and ALK positive patients, and this is based on Adura trial, which included patients who underwent upfront resection, followed by chemotherapy and osimertinib. Chemotherapy was not given to all patients, but this is a very important trial that showed benefit in survival. The last one was ALINA trial, which is in ALK positive patients, likewise underwent upfront resection and then received for 2 years alectinib, and this trial also demonstrated better disease-free survival. So this is the current landscape. However, what are the new trials that are coming up? Some of these are phase 2, some of these are phase 3, in order to improve outcomes in patients with lung cancer. So there's an effort through the LCMC4 and LEADER trial to start using targeted therapies earlier than in the adjuvant setting, and this would be in the neoadjuvant trials. And as you can see over here, right now we have at least 12 biomarkers for which we have active drugs. They include, besides EGFR and ALK, they also include RET, BRAF, ROS1, NTRK, HER mutations, MET mutations, and I should also mention, which is not on this slide, that there are drugs for KRAS. And so all of these actionable drivers have very effective drugs that are now being tested in the neoadjuvant setting. The LEADER trial was designed to screen patients for these mutations and then eventually enroll them on the trials that are based on targeted therapy. So the aim of the LEADER trial was to enroll 1,000 patients with stage 1 to stage 3 disease. As you can see, the aim is to profile these patients up front for PD-L1 and some of these targetable mutations, and then enroll patients on these matched targeted trials, followed by surgical resections. And there are numerous analyses for these trials, such as major pathological response, pathological complete response, as well as circulating tumor-free DNA. So one of those trials that LEADER trial feeds into is a Nautika 1 trial. As you can see, this is a trial for patients with stage 1B through 3A, through 3B disease with ECOG PS of 0 to 1. And if the patients have any of these mutations, such as ALK, ROS1, NTRK, BRAF, RED, or if they don't have any targetable mutations and they have PD-L1 positive tumors, they could be enrolled on neoadjuvant therapy, either targeted therapy or treatment with atezolizumab plus low-dose SBRT, followed by surgical resection. And then patients following surgical resection are evaluated for pathologic response, and then they are treated based on standard of care treatment in the adjuvant setting. So this trial is ongoing. Some of the early results from ALK positive cohort have already been presented and published in abstract and presentation and early paper setting. So again, in another very important trial is a Neoadura trial. As we know, the Adura trial used patients who underwent upfront resection, and then they were treated for up to 3 years with osimertinib. Neoadjuvant trial brings this concept, Neoadura trial brings this concept into the neoadjuvant setting where patients are profiled upfront, and if they have either exon 19 deletion or exon 21, otherwise known as L858R mutation, and they are resectable, then they are randomized to these 3 arms, either osimertinib plus chemotherapy, chemotherapy alone with placebo, or osimertinib alone, followed by surgery. The primary endpoints are major pathological response, and you can see that there are lots of secondary endpoints, and this is an important phase 3 trial that may in fact potentially change standard of care in EGFR driven tumors. Another very important trial in this setting that has an opportunity to change standard of care, although this is only in phase 2, is Neocoast 2 trial. This trial actually tests some new drug regimens. And again, the enrollment for the patients is patients with resectable stage 2A through 3B disease. As you can see, it's important to rule out EGFR and ALK, and this is pretty much a standard of care now for any of the chemoimmunotherapy regimens. But these regimens are slightly different. You can see that there are multiple arms that are testing either standard immunotherapy, such as durvalumab, plus oleclumab. Oleclumab is a CD73 inhibitor. Then we have monalizumab, which acts against natural killer cells. And then we have these other monoclonal antibodies in arm 4 and 5. And in arm 3, there is a drug, volrustomig, which actually is a combination of anti-PD-1 and CTLA-4 inhibitor. So once again, these patients would undergo neoadjuvant treatment, followed by surgery, followed by adjuvant treatment. And again, primary endpoints are pathological complete response and other secondary endpoints that are pretty standard, such as event-free survival, disease-free survival, and overall survival. The Neocoast 1 trial has already been presented, and I think this is an excellent follow-up on the trial and will hopefully bring some new treatment paradigms for patients. And lastly, a phase 2 trial, MDT Bridge. I think this is an excellent trial that looks at patients who are marginally resectable with stage 2B or 3A disease. We oftentimes encounter these patients when there's a difficult decision between neoadjuvant chemoimmunotherapy followed by surgery versus treating patients based on concomitant chemoradiation and immunotherapy based on Pacific regimen. So this trial takes into account all of these factors and allows people to get 2 cycles of durvalumab plus immunotherapy, and then decision is made whether the disease is still resectable or unresectable. If it's resectable, patients receive 1 or 2 more cycles, followed by surgical resection. If there's a change in treatment, patients undergo chemoradiation, and then they undergo consolidation adjuvant therapy. So this is a very important concept for these marginal resectable patients. Thank you very much for your attention.